I'm going to talk about bloodless medicine in obstetrics, which is something that's near and dear to my heart. I first got involved with bloodless medicine about 1995 when I arrived at the Cleveland Clinic and was introduced to a nurse, Sharon Vernon, who had created a bloodless institute at a hospital in Cleveland to teach people how to develop bloodless medicine programs. And I think this is the heart of what has evolved into patient blood management. But in the mid-90s, we recognized that bloodless medicine was not just good for Jehovah's Witnesses, it was good for everybody. So we started engineering the terminology around it so that it was more acceptable to all care providers. So the foundation really of bloodless medicine has been the care of Jehovah's Witness patients. And in our program in Pittsburgh, we take care of about 1,600 Jehovah's Witnesses on an annual basis, with about 25 of them achieving what we consider critical anemias, meaning less than 6 grams per deciliter of hemoglobin. And surprisingly, I didn't realize this until I moved to Pittsburgh, but the foundation of the bloodless medicine movement really is Pittsburgh. The Jehovah's Witness Church was founded here in 1872 to 1874, depending upon who you talk to. And this is a plaque commemorating the foundation of the Jehovah's Witness Church on the north side of Pittsburgh, right down the street from our football stadium, Heinz Field. These are the foundations, and I'm sure everybody is familiar with these scriptures, so I won't belabor it. But the Jehovah's Witnesses basically reject all the prime components of blood. It gets kind of gray when we start talking about components of blood products. And this has kind of been the heart of our bloodless program, is trying to educate our patients as to what these components are and allow for the patient to make conscious decisions about whether or not they'll accept those particular components. So one of the foundations of our program is to identify patients that would refuse blood products. And in our nursing assessment on admission to our hospitals, in the center of this screen are questions to try to identify whether or not a patient is advocating for bloodless care, and whether or not they would like to be approached by a member of our bloodless medicine team. And so these are the questions, basically. And this is our bloodless medicine advocate, Deb Tatro, who will basically consult with any patient that is advocating for bloodless care. In 2018, she performed 411 inpatient and outpatient consults, talking to patients and educating them. And this is the note that she puts into our medical record, just identifying whether or not these patients will accept various kinds of care. And if you're interested, we have a fairly large set of resources on our internet. This is our bloodless medicine and surgery services, what we provide, and it can be reached by that link down below. So what I'm really here to talk about today is obstetrics and bloodless care as it applies to obstetrical care. This is some work that came out of the CMQC, or the California Maternal Quality Care Collaborative in California. And what you see here is that obstetrical hemorrhage is one of the leading causes of maternal mortality in California, with hemorrhage having the most preventable cause of death in this particular set of data. One of the interesting things that came from this particular piece of work was that the response to a bleeding woman was delayed in many circumstances. And this primarily relates to young women have remarkable reserve to tolerate significant hemorrhage until they just kind of fall off a cliff and die. And they'll look pretty good up until that point that they arrest. So the CMQCC is advocated for early warning signs that somebody is bleeding abnormally. And so they've advocated for something called the qualitative blood loss measurements. And so by doing this, which is the slide showing weighing of flap sponges or swabs, you can get a more qualitative estimate of what the patient has lost in terms of blood. And then the conversion from weight to milliliters is simple. 1 gram equals 1 milliliter. So if I'm weighing your lap sponges and measuring the volumes in any suction canisters, you get a more precise measurement of what the patient has actually lost. And so this is one of the prime tenets of what the CMQCC has advocated is measurement of, or accurate measurement of blood loss during delivery. So there's been a pretty big advocacy for development of checklists. You know, when you get into many of these circumstances where a woman is bleeding abnormally, oftentimes we forget about things that we should be doing. And so we've created checklists in our facility, not just for the anesthesiologists, which is what this checklist is, but also for our obstetricians and for our nursing staff in the operating room, so that we don't forget key areas of care. So probably the most important area is making sure that you have adequate intravenous access. This has been a problem for us as we get patients that get life flighted in from rural parts of our state. They oftentimes show up with inadequate IV access. We had one woman who arrived with a 22 gauge IV that was partially in and partially out. She subsequently arrested and died. So we started looking at ways that we could prevent this. And one of them was an intraosseous drill, which is shown here. This device drills into long bone marrow, and you can basically run an IV or an intraosseous needle at a rate that's equivalent to a 16 gauge IV. So it can be life-saving. And these can be placed in a matter of seconds. To place one of these is probably a 3-second procedure, and they run remarkably well. So I would advocate to anybody that's out there doing obstetrical care is consider getting one of these drills. Other things, aortic cross-clamping, when I initially trained, was something that we would do anytime we had penetrating abdominal trauma. There is a new device here, the REBOA, or the Retrograde Endovascular Balloon Occlusion of the Aortic device, that is primarily used in trauma care. But the trauma surgeons that I've interacted with have said that this device is probably most successfully deployed in pelvic hemorrhage, which would be any delivery excessive blood loss. And the device is deployed through a femoral artery and is placed basically by the measurements from the patient's belly button. And it can be placed below the renal arteries and occlude the aorta and blood loss that's taking place from a bleeding uterus, so that more definitive care can take place without there being massive blood loss. Other things that I think are important is constant monitoring of patients' hemoglobin and their coagulation function, which is easily done, at least in the United States, with something called a HemoQ and a thromboelastograph. This is the newest generation of a thromboelastograph that uses a cartridge-based technology. And you get 4 different waveforms from this device that tells you what is broken in the coagulation system. One of them, the lowest light blue color, is a functional fibrinogen, which translates here in the lower right-hand corner of the slide into a fibrinogen number. In this case, this is a pregnant woman who had a fibrinogen count of 600, and this correlated pretty closely with the Klaus measurement of fibrinogen. And by the way, the name in the upper left-hand corner is the sales rep, so it's not a disclosure of HIPAA-protected information. At any rate, that device can be quite useful in the management of hemorrhage. Some of the other technology, this is a Bakri balloon, which basically does a tamponade of bleeding uterus by inflating the balloon and putting pressure on the side walls of the uterus. Bleeding can stop. A newer device is something called the JATA device. This device actually does the opposite to the Bakri balloon, in that you place suction to the device, and it basically collapses the uterus from the suction-induced pressure. And we've found that this device is even more effective than the Bakri balloon in controlling obstetrical hemorrhage. Other areas, this is really what I wanted to get to, is autotransfusion, or the use of cell salvage. There's many names for it. Cell salvage is one of them, or blood salvage, or autotransfusion. I think probably the more correct language around this technology is autotransfusion. And the whole concept of autotransfusion, in other words, the collection of shed blood, its reinfusion into the person shedding it. This concept was first proposed in 1874 through this paper in The Lancet by William Highmore. And it was basically in the observation of a young woman bleeding to death following delivery, where Highmore proposed that perhaps in the bottom paragraph here, that the hemorrhagic blood of the woman could be collected, defibrinated, and warmed, and then readministered through a Higginson's syringe and a transfusion pipe. So this is the way that transfusion really took place over probably the next 50 years, was that shed surgical blood was reinfused in this fashion, where it was just collected and filtered with gauze. And we can still do this in this day and age. There was a number of different reports in the literature during this era where unwashed autotransfusion blood was used. This is one of the reports that basically stated that the side effects of administering this unwashed blood were fairly minimal, unless there was old blood that was collected and re-administered. So this has evolved. This is a device, the Hemofuse, is a device developed one of the University of Pittsburgh Bioengineering students as her senior design project. And it's basically a giant syringe that's intended to collect blood from any bleeding patient. And then the plunger is pushed and the blood is transferred into a bag for collection and re-administered. So this is basically a device that makes it a little more friendly than what was being done by William Highmore back in 1874. But this device has been approved by the United States FDA for use in the United States, surprisingly. And it gives back basically whole blood to a patient. And Jillian, who designed this device, has tested it in several different countries in Africa. So this is an opportunity for use of autotransfusion in low-income countries. So in the United States, this idea evolved into this device, which was a device that was intended to suck blood out of a surgical wound into the spherical reservoir on the top. And then it was intended to be pumped back into the patient by the roller pump that's shown. The problem with this device was that the roller pump wouldn't stop when the reservoir was empty. So there was a number of air emboli that took place from this device. And so it was very quickly removed from the market in the United States. But it's kind of the forerunner to the development of modern autotransfusion devices such as this. This is a machine that's manufactured by Sorin. It just happens to be the one that we use at the University of Pittsburgh, but it works well. So classically, there has been contraindications to the use of cell salvage or autotransfusion in obstetrics, and the fear has been of basically entraining amniotic fluid and then giving a iatrogenic amniotic fluid embolus to the patient. This really was a labeling contraindication. It wasn't a true contraindication, meaning that the United States FDA basically for the original generations of these devices wouldn't give approval for labeling in obstetrics because there was no scientific evidence of safety. So the manufacturers of the devices simply labeled the devices as being contraindicated in obstetrics. So that's the foundation for the contraindication. It's a labeling contraindication, not a true contraindication. We should be very fearful of amniotic fluid embolism because these are the consequences of having such an entity occur to one of our patients. However, there's really no definitive causative agent for amniotic fluid embolism. It's a normal part of delivery is that amniotic fluid will be entrained into the maternal circulation. But amniotic fluid embolism by itself is bad in terms of the mortality rate and those that actually don't die. Most of them are neurologically injured. So we really don't want to be causing this if we can help it. However, there's no evidence, as I mentioned, that amniotic fluid really results in an embolic phenomena. And to share some of the data, around amniotic fluid, this is some work that was done in Peru in the mid-1950s, where this investigator, Tio, used amniotic fluid to basically fix coagulation dysfunction. So he injected it into women who had coagulation abnormalities in doses of 5 to 500 mLs with basically nothing happening other than the coagulation abnormalities resolved. And then he proceeded to do the same thing with men and children, where he injected amniotic fluid in these doses to 73 patients of all ages without there being an effect. So simply the amniotic fluid seems to not be associated with an embolic phenomena based on that piece of work. Now, there has been some animal models that have tried to replicate the amniotic fluid embolic phenomena. This was a rhesus monkey study that was performed where the investigator removed amniotic fluid from these rhesus monkeys and then injected it into their circulation and found that basically nothing happened from its administration. Then this investigator, who happens to have worked in my facility at Magee-Womens Hospital back in the mid-70s, he took the placenta, he ground them up, and then he took an extract of that placenta and then injected it, which resulted in cardiac arrest in these animals. And basically what he found is that it caused a consumption of fibrinogen, which maybe because it led to basically massive clot formation within the circulation of these animals. So it starts to hint that perhaps tissue factor is one of the causes of this phenomenon. In a separate piece of work, this investigator looked at injecting amniotic fluid that was meconium stained into a pig and found that the same kind of thing happened, is that a severe coagulopathy and cardiorespiratory arrest would occur. But if clear amniotic fluid was used, then nothing happened. So again, suggesting that tissue factor might be a big component of this particular problem. So most recently, the amniotic fluid embolus phenomena has evolved to the point where many investigators are now labeling it as an anaphylactic reaction rather than an embolic phenomenon. So this particular investigator suggested that a more correct terminology might be anaphylactoid syndrome of pregnancy. So once again, we're left kind of hanging in terms of what the mechanism of this problem is. One of the problems is that if you do a sample size calculation, in order to prove safety of autotransfusion and obstetrics, this is the result, is that the incidence of an amniotic fluid embolus is about 1 per 19,000 deliveries. So if you do a sample size calculation to prove safety of this technology in obstetrics, you need 1.7 million subjects. And that kind of size and scope of a study will never happen. So we need to really consider surrogate measures of safety in obstetrics. And so these are the questions I asked myself before advocating for the use of autotransfusion in obstetrics. Can we wash out the biochemical contaminants, that tissue factor that I referred to earlier? Can we remove the cellular contaminants? And can we remove bacteria to a safe level? So the biochemical contaminants have been studied in the late 90s. This investigator looked at the washout of tissue factor. This was simply a washing cycle, and he demonstrated that tissue factor could be completely washed out through a typical autotransfusion washing cycle. What about the particulate contaminants? This is what I've advocated for, is the use of a leukocyte depletion filter. As is shown here, this particular filter was designed for use in salvage or autotransfusion. It has higher flow rates than the type of leukocyte depletion filter that the blood bank uses. So it is quite useful in this particular environment. And just to show how useful it is, this is some blood that was collected from a cesarean section. And what you have here is these red things are squamous cells from the skin of the fetus. The black dots are leukocytes, and then the green material is what the pathologist that I worked with on this study called amorphous skunk. And then in the background, you can see hints of red cells. The staining of the red cells is not great, but will higher power magnify this particular blood after washing. This is what it looks like. And now the red cells are much more visible. But we still have these leukocytes and we still have the squamous cells. The amorphous gunk is gone with the washing. But when we use one of these filters, this is the result, is that we remove all of those squamous cells, we remove all the leukocytes, and all we're left with is red cells. So it appears that we can remove the biochemical contaminants, the cellular contaminants. This was a study that I published 20 years ago, where we looked at 5 different measures of amniotic fluid contamination of blood that was salvaged. And we drew a maternal blood sample at the point of placental separation. And we looked at these contaminants against a post-washed, post-filtered blood sample. And we found that across the board, the blood was equivalent or even cleaner than what was actually circulating in the mother. So this was kind of a foundational study in terms of demonstrating safety of this technology in obstetrics. What about bacterial contaminants? This was another study that I published where we contaminated units of blood from the blood bank with these 4 different bacteria, which my surgeon reported were the things that they feared the most. And then on the far right-hand portion of the slide, we looked at how much of the bacterial contamination we could remove. And what we found is that we could remove somewhere between 97 and 100% of the bacteria with a washing and filtration treatment of the blood product. So with 97%, it means that you still got a little bit left. However, this is some work that Rosalind Yantovian at Case Western in Cleveland published, as the contamination of platelets prior to the administration, and they weren't sterile across the board, as is shown in the left-hand column. So fundamentally, from trauma work, the combination of washing, filtering, and the administration of antibiotics should provide a safe blood product for patients. This is a collection of case series that Giancarlo Liambruno in Italy had put together back in 2011, where he collected 1,665 cases of autotransfusion being performed in obstetrics and found no adverse events that took place in these 1,600 cases. And me and my colleagues about 3 years ago published a case series of 880 cases that were performed here with total safety being demonstrated. As a result, all of these organizations recommend that autotransfusion be the primary approach to maternal hemorrhage when it happens. And so just some practical aspects to make this safe and to better collect blood during the course of salvage. One of the problems with obstetrical hemorrhage is it's unpredictable. So in the back of my operating room, I have a suction reservoir such as this, a ring clamp, a suction line, and a bag of anticoagulant. More recently, we've started using something called a hemosaver in our labor and delivery rooms for collection of blood, and then we can transfer that blood easily in a sterile fashion into a collection reservoir such as this for ultimate processing. And we've had some pretty remarkable hemorrhages in our vaginal cases where we've lost up to 20 liters of blood. So being able to collect blood, not only from cesarean sections, but from vaginal hemorrhages is something that we should be striving for. And this is what you can do as a stopgap measure, is what I call a standby system. where you just set up a collection reservoir, a suction source, and the anticoagulant. So when to utilize this technology, we generally use this as kind of a drop dead point of when we start thinking about bringing a machine into the room, is when we've gone through 4 packs of swabs or laparotomy pads. That is an average number of laparotomy pads that are used for routine cesarean section. So when we've gone past that point, we've encountered abnormal bleeding. One of the most effective things that can be done in obstetrics is demonstrated here, where we rinse lap sponges. And this is a fully soaked lap sponge that's being rinsed out in a basin of saline, with the fluid being suctioned into a suction canister, and then it can be processed. And by doing this, we can remove 95% of the red cells. So a fully soaked lap sponge, such as is shown here, will contain 100 mLs of blood. So it doesn't take long before you have an entire unit of blood through these lap sponges. And in obstetrics, most of the blood loss that takes place during the course of any kind of care usually goes on to these sponges, rather than into any wall suction canisters. So it's really imperative that this is done during the course of care. So I've mentioned filters. There are a number of different biological filters that can be used for filtering blood. There's what are called screen filters, and then there's depth filters. In the suction reservoir, as shown here, there is a screen filter that basically filters out microaggregates. And this is what a screen filter looks like under magnification. It's basically like a window screen. It'll remove anything that has a size that's bigger than these holes. Everything smaller will move through that screen filter. And these are the filters that you can find. On the far left is SQ40 filter, which stands for square, and 40 microns is the size of the filtration. The middle filter is a Lipogard filter that's used for removing fats. And on the far right is a Leucogard leukocyte depletion filter that works a little bit differently. It's a depth filter, so blood flows into a depth of polyethylene fibers, and is removed not by that screening function, but adhesion to the filter material. And this is what it looks like under magnification, is that the blood will flow through what is initially a very loosely packed polyethylene fiber to a more densely packed polyethylene fiber on the right side of the slide. So the contaminants basically adheres to these fibers as it moves through the filter. So just to finish, these are a number of the different machines that are available on the market. There has been some propagation of information that with the care of the bloodless patient, that there should be a continuous circuit that's created. And I think that's probably a marketing ploy from the machine on the far left, which is a continuous autotransfusion system that it was intended to continuously process blood, whereas these machines that I've highlighted here on the right side are batch processing. But in conversation with the Watchtower in New York, there is no doctrine that's propagated for the care of the bloodless patient that requires there to be a continuous circuit. It's up to the conscience of the patient as to whether or not this technology should be deployed. So when I say a continuous circuit, this is kind of a diagram of what that continuous circuit would look like. But again, there's no doctrine within the church that requires this continuous loop. So This is from a case report that I published with Paul Potter back in 21 years ago. It's amazing that that amount of time has passed. But anyway, we basically highlighted this conscious of the individual as to whether or not the batch processing would be applicable. And so I will stop there. Thank you for listening.